We had good progress in the last few months. We have resident and fellows projects from different programs. We exceeded now 30 ICU resident and fellows projects. We had several publications by several colleagues. One of them is Dr. Hani has published his article. So congratulations, Dr. Hani, for the paper on simulation. It's a good paper. There are other Dr. Ayman Kharaba published his paper on so it's been great, and we encourage residents and fellows to attend these meetings regularly. So I think one of the strategies is to try to expand the critical mass of people who are doing research. And as you know, the Saudi Commission has made it mandatory now for the residents and fellows to have a research project. And I think this makes a lot of sense, that in the 2-year fellowship or 5-year residency, there should be a production of at least one publication. And so it's good for the residents to be engaged. But critical care is multidisciplinary, and engagement of the nurses, respiratory therapists, physiotherapists also is essential in this process. I don't know if there are comments from the group. Maybe Dr. Hani Temsah, do you have any comment on this while we're waiting for Hani?
Allah salamtak ya Prof. Thank you very much. Very proud to have great collaborations both nationally and internationally, and I'm sure having more fellows, more residents join the efforts, I'm sure it's going to be fruitful for everyone. Thank you, Prof.
How can we get the fellows and residents from other programs engaged? Do you think we have the all what's needed to get residents supported in different programs?
I am sure. For example, I'm from the pediatric background, so not only the PICU fellows. So I know there are so many, almost now all the residents, they are looking to have a real solid research in progress. So most of the residents I've noticed, they don't want just to have an IRB proposal approval and that's it. So they are seeking for publications. So I'm hopeful that I think we can invite from other disciplines every now and then, Prof, because some people, they want to join, but they don't know how, apparently. Or they just come with a short notice and they think it's a quick, the research is not a quick push of a button. It needs months and sometimes more than a year of preparation and ongoing and publication. So I think one session dedicated for the other residents, I think it's worth it.
Agree.
Yep. So perhaps we can set it up in one of the, at least as one of the side topics, and we can invite one of those key speakers, especially from, I know a couple of colleagues in the Saudi Commission, so maybe they can help because the residents will listen to them. And it can be, again, another core nationwide with the initiation process through the Saudi Critical Care Society.
Good idea, Wallah. Maybe you can invite somebody from the Saudi Commission. I think it's a great idea. Dr. Hani is having technical difficulty with the, Rose, can you communicate with Dr. Hani?
Doctor, I'm sorry, I don't have his number.
He's having difficulty logging in.
Does he have the same link, or maybe he's using another link?
Hani, are you here?
Yes, I got it.
Okay, good. So can you make him host?
Yes,
Rose?
doctor. Yes, doctor. It's okay now.
So thank you, Hani. I think Dr. Hani will talking about inferential statistics today. Last time we talked about the descriptive statistics. So thank you, Hani, for the time, and sorry for this technical glitch.
Yeah, Assalamu alaikum. Thank you very much, Dr. Yassin. And sorry for being late, but I had a technical thing, as you said. So I'm gonna start. Till what time do I have?
Well, the meeting will finish at 10, so if we can leave at least 5 minutes for discussion.
Okay, all right, perfect. So I will try to make it in 30-35 minutes, and I'll leave maybe 10 minutes for any question. As mentioned by Dr. Arabi, we have descriptive statistics and inferential statistics. We covered the descriptive with all the numbers and percents and mean and standard deviation. And now we move to the inferential statistics. Before I go into inferential statistics, I just want to talk about a few things that will prepare us for the inferential statistics. Number one, we have the distributions. This is a distribution for a continuous variable. And the area under this curve is 100%. And you can imagine a bar, some bars here, like a histogram, with each one having a separate probability, where you end up with the total percentage being 100%. So this is a very unique distribution that we call normal distribution or symmetric distribution. And this is because the left side and the right side are equal to each other. And mean, median, and mode are also equal to each other. So you have another type of distribution which is skewed to the left, meaning as if the graph has been pulled to the left, to this side, where the mean will be smaller than the median, smaller than the mode, and the other side is skewed to the right, where it is pulled to the right, the mean will be larger than the median, larger than the mode. Now, these two skewed distributions, we do not usually work with them a lot. What's really interesting about the distributions is the normal distribution or the symmetric distribution. Probability, I just want to say a few words about probability. Probability is the likelihood that a given event will occur. And it ranges from 0 to 1. 0, it's impossible. 1, it's definitely happening. And the way we calculate probability is by something we call frequentist approach. What does frequentist approach mean? It means it is the long-term relative frequency. For instance, if you are looking at mortality in ICU, for example, you will look at the past 100 patients admitted to the ICU, and you will get the relative frequency or the percentage of people who died during the past period. And then this probability or this percentage will be the probability for future patients who will be admitted to the ICU. Now, why am I mentioning the probability? Because the probability is the most important theory behind biostatistics. And there are so many things that are related to probability, such as incidence, prevalence, relative risk, odds ratio, and so on. So everything we do in statistics, it's based on probability distributions. This is exactly the same, relative risk and risk difference and so on. All of these are based on probabilities. So probability is applied at all levels of statistical analysis. More specifically, we have something called probability distribution. You might remember what a probability distribution is, but briefly, it is the listing of the the distribution of all the probabilities for a certain variable. What do I mean by that? We have two types of distributions: the probability distribution for a categorical variable and for a continuous variable. For categorical variables, if I tell you what's the probability distribution for mortality, it will be 20% mortality and 80% survival. So just by giving these two numbers, you have the distribution of the probabilities of the occurrences of this variable. What's more challenging is the continuous variable. And more specifically, we have the Z and the T distribution. So what is the Z distribution? The Z distribution is a hypothetical normal distribution that has mean, median, mode equal to each other, and it looks like a bell, and it is, hello? Yeah. And it is used to get the probabilities, and it is directly related to the p-value and the confidence interval that I will be talking about. So in any normal distribution, we assume we have an average of 40 and standard deviation of 10. All the area under this curve is 100%. So when I look at this distribution, I can tell you that 50% of the patients are below 40 years, for example, and the other 50 is above 40 years. But what if I ask you, what is the probability between 25 and 40? So what you need to do is you need to calculate it through a certain equation, which is very complicated. That's why somebody came and said, you know what? Why don't we take one normal distribution with an average of 0 and standard deviation of 1 and do all the calculation? And they did that. And eventually, for this normal distribution, they calculated all the probabilities. This is the Z distribution, or the Z table, if you remember it. I don't want to go in details about the Z table. All what I want you to remember, and I think you do remember, that the probability between an average minus 1 standard deviation and plus 1 standard deviation is 68%. And you get the 68% from this table that I just showed you. So anytime I have an average, if I subtract 1 standard deviation, so 40 minus 10 and plus 10, I always have 68% data in between. Now, what if I remove 2 standard deviations and add 2 standard deviations? It will be 95%. And if I do 3 standard deviations, it will be 99%. So for any distribution, as long as it is normal, the probability between 1 and 1 standard deviation is 68, 2 and 2 is 95, 3 and 3 is 99. Now, so far I have covered what I want to cover, so before I start with the inferential statistics. So inferential statistics is the process of using the sample statistic to make informed guesses about the value of a population parameter. So what do I mean by that? Whenever I do a study, my question is about the population. So the research question that I pose is about the population, about all patients admitted to the ICU or all patients with hypertension or whatever it is. But practically, I do not take the whole population to be able to get the exact answer that I want. What I do is I take a sample of 100, 200, 500 patients, I do my analysis, and the results I get are going to be on the sample itself. But my question is originally for the population. The best that I can do is to use the results of the sample to make informed guesses. After all, it is a guess. It is an estimation, but it is not a rough guess. I'm not guessing out of nothing. I'm guessing based on information. That's why it's called informed guess. So I use the results of the sample to make an estimation or an informed guess about the population number or population relative risk or population whatever. And this slide specifically shows this idea that I just showed you. This is a whole population of whatever characteristics of patients you have. The question is about the whole population. You take a sample and the results of the sample are specific to this sample. So what I need to do, I need to figure out a way to make inferences or drawing conclusions on certain questions about a population using the results of the sample. And this is what we call inferential statistics. So since we are not taking the whole population, we have to draw conclusions on the population based on results we get from the sample. I'm just repeating myself. Simple example. Say we want to estimate the average blood pressure of patients admitted to the emergency department after having an MI. It's a very simple question. It might not have clinical justification, but I just want to highlight what the inferential statistics are. Of course, other more complicated measures might be satisfaction, quality of life, risk of outcome, and so on. But I'm gonna limit it that our question is an average blood pressure that I want to measure for a certain group of patients. Now, what do? We take a sample, assume we took a 291 patients, admitted to the emergency in a certain hospital, and we calculate the mean and the standard deviation, which are the descriptive statistics. And we find it to be 144 and 35 as a standard deviation. Now, this 144 and 35 are only among or for the 286 people. But again, my question is for everybody. So what do I need to do? I need to do the inferential statistics. The next step is to make the link between the estimates we observed from the sample and those of the underlying population. And what can we say about these estimates as compared to the unknown true ones? Or we are trying to estimate the blood pressure of all patients admitted to the emergency after an MI. So I go back to the distribution that I just talked about. This is the normal distribution of the systolic blood pressures of my sample, which is average 144 and the standard deviation of 35. Now, in inference, I have two things that I can do. Number one is to estimate the value of the population, and this is the confidence interval. Or the second one is to evaluate a hypothesis about the population or answer a question about the population, and this is the p-value. So I'm going to start with the first one, which is the confidence interval. If you just look at the name of a confidence interval, the interval is two numbers that define a certain set of values. The confidence is how sure you are. And usually in research, the way we show our confidence is by probability, by percentage. I can tell you I'm 90% sure, I'm 100% sure, or I'm 95% sure. So the confidence interval is an interval with a 95% probability that the true population is within. Let me show you how to calculate it and you'll be able to further understand it. The confidence interval is made from a point estimate, one value, and around it, I put two numerical values defining a range of values that with a specified degree of confidence or percentage, it includes the parameter being estimated. Let us go back to our example. When I'm talking about the systolic blood pressure, I found that the average of the sample is 144 and standard deviation of 35. So if I tell you what's your best guess of the population average of the systolic blood pressure, based on your sample, the only answer you can get is that it's 144, because this is the average of the sample you got. But you cannot give me one value for the population because there's a lot of error that might have happened. So what do? I want to draw a certain confidence around it. And usually we calculate a 95% confidence interval. Now, if you remember what I mentioned about the Z table, I mentioned the 95%. When we talked about the 95%, we said that it is 2 standard deviation below and 2 standard deviation above. And this is exactly what I'm doing. I'm saying the 144, which is the average from the sample, plus and minus 2 times standard deviation to get the 95%. So this is how I get the confidence interval, but there's only one thing that I need to add, which is dividing by the sample size. Why do I divide by sample size? Because I want to adjust for how big my sample is. Now, if I take a huge sample size, your estimation logically should be better. And by being better, the width of the confidence interval should be narrower, meaning you're giving me almost one number. So as the sample size increases, this whole thing that's called standard error goes down. And thus I'm adding and subtracting a smaller number from the average, and thus the confidence interval will be narrower. But if I take 50 patients, for example, very small sample size, my estimation will not be very good, and thus my confidence interval will be wide. So as this decreases, this whole thing increases, and thus I'm adding and subtracting a bigger value, and the confidence interval will be wider. So the calculation is very simple: average plus minus 2 standard errors, we call it, which is the standard deviation over square root of n. Now, this is the 95% that I talked about. This is the standard error that I talked about. As sample size increases, the error would decrease because this whole thing will go down. So how do we interpret any confidence interval? The confidence interval usually is 95%. It is then there is 95% probability that the true parameter of the whole population that you are interested in is within this interval. When I say 95% confident or probability that it will be within, then there should be the other 5% as an error, and this is exactly what it is. So it will be 95 times correct, but wrong 5 times. So researchers agreed that a 5% error or probability of 5% that I will be making a mistake of saying that this is where my true population value is, but it is outside, it's only 5%, I can live with it. So that's why we consider a 5% level of error in most of the studies that we do. Interpretation, it provides the level of confidence of the value for the population average blood pressure. Are all confidence intervals 95? No, it is the most commonly used one. So if you open a paper, most of the times you will find a 95% confidence interval. Very rarely you will find a 99 or a 90% confidence interval. Actually, 90% is very rare. 99 is a little bit more frequent, but definitely very rare as compared to the 95. And the reason why people put 99 confidence interval is when they have a huge sample size, when they do not want to report 5% error, they want to tell you as a reader, I'm only having 1% error because my sample size is very big. I will move to the p-value. The p-value is a probability. So what does it mean? It's related to another type of inference, and it's called a hypothesis test. So what is a hypothesis? A hypothesis is a statement that might be true, that might not be true. So whenever you want to do a study, you pose a hypothesis on the population, which you do not know, which might be true or might not be true. So instead of estimating the value of the population, like the confidence interval, I'm saying I'm going to evaluate the hypothesis. So the bottom line is that assume that we're going back to the same example, average blood pressure among ED patients. Assume that the normal systolic blood pressure is 120. I would pose my hypothesis or my question, is the systolic blood pressure for all the patients, the population admitted to the emergency with an MI, is it 120 or not? So what do? I put two hypotheses. One is called null hypothesis and one is called alternative hypothesis. Now, the null hypothesis is always saying no, no difference, no association, no effect, no correlation, whatever it is. The alternative is the opposite of the null and saying, yes, there is. There is an association or there is an effect or whatever it is. Now, how do I decide on it? To decide on which hypothesis is true, I take a sample from the population, like we did in the 291 patients that we took from different hospitals or one hospital. If the data is consistent with the null or it is supportive of the null, then eventually we do not reject the null and we accept the null and we say the null hypothesis is true and there is no difference. More specifically, we say no significant difference. Now, if the sample data are not consistent or are not supportive of the null, or they are supportive of the alternative, I reject the null, I accept the alternative, and thus my conclusion will be there is a significant difference. So I'm just gonna go back very briefly. Null hypothesis saying no association, alternative hypothesis saying there is an association. If the data is supportive of the null, I say null hypothesis is true, no difference or no significant difference or no association. If the data is supportive of the alternative, I would say there is a significant difference or a significant association. Now, This is the example I had before. I would say that the null hypothesis that the average blood pressure for all patients of the whole population is equal to 120, meaning normal blood pressure. The alternative is, no, it's not equal to 120. It's different. It's abnormal. So what do? I take a sample and find that the average is 144. So can we consider the 144 consistent with the null or the alternative? If you tell me it's supportive of the alternative, then you are seeking clinical significance, not statistical significance. Yes, as a clinician, you might be able to say that 144 is very far away from the 120, thus I accept the alternative, but this will not be statistical, this will be clinical significance. For statistical significance, you have to do some calculations, and according to the calculations, decide whether you accept or reject the null hypothesis. How do we do that? I assume that the null hypothesis is true. And remember, the null hypothesis is 120. If my sample average is around here, which means among the bulk of my data, then I would say this sample is supportive of this 120. But if my sample is far away from the 120, I say it's beyond this lump, and it is not supportive of the null hypothesis, so I reject the null hypothesis, I accept the alternative. So if you understand this, I can go further to how do I decide? I decide on it based on a probability. I calculate a probability of getting this sample if this is true. Because this is the majority of the data, the probability for something like this is going to be big. Whereas probability for something away is going to be small. So if the probability is big or large, then it is supportive of the null, no significant difference. If the p-value or probability is small, it means it's far away from the null. I reject the null, I accept the alternative, and I say there is a significant difference or significant association. So I'm just playing with a large p-value and a small p-value. So what is the cutoff point where I say this is large or this is small? It is the typical p-value that you know about. And it is the 95% in the middle and 5% at the extreme. So if the sample is on the extreme, the p-value should be less than 0.05. If more than 0.05, then I assume that it is in the middle and I accept the null hypothesis. So the bottom line, I calculate a probability that's called p-value. If the p-value is more than 5% or 0.05, I consider it as a large probability. Thus, it is in the middle. Thus, I accept the null hypothesis and I conclude no significant difference. If the p-value is less than 5% or less than 0.05, I would know that it is at the extremes. It is not consistent with the null. I reject the null. I accept the alternative, and there will be a significant difference or significant association. Now, this is exactly what I just said. This is what I said, but in words. If the p-value is low, then it's taken as evidence that it is unlikely that the null hypothesis is true. Then we reject the null hypothesis, we accept the alternative. If the p-value is high, it indicates that most probably the null hypothesis is true, and thus we do not reject the null hypothesis. I'm gonna skip this part, which is the type 1 or type 2 error. But basically, type 1 error is when I reject the null hypothesis when it is true, and it is 5%, which I take as the allowable or permissible level of error. That's why if you open any paper, you go to the statistical analysis section, most likely the last sentence of the statistical analysis section will be about what is the type 1 error that you considered in your study. And most of the times it is 5%. So you would say type 1 error was considered at 5%, or p-value of less than 5% was used to indicate statistical significance or something like that. Now, this is exactly what I said before. So p-value less than predetermined cutoff 0.05, then it's statistically significant. Back to the example, this is the null hypothesis 120. I carry out, okay, so in the next 10 minutes, what I'm going to be doing is I'm going to show you different tests that we use in statistics. One is called one sample t-test, another is called independent t-test. We have chi-square, correlation, and Anova. So I just want you to understand which one is used when and how to interpret it. So the first one is one sample t-test, which is similar to what I mentioned before. This is the output of SPSS. And I find that the significance here is 0.000. What does it mean? This is the p-value. What does it mean, a p-value of 0.000? Does it mean it's zero? No, it's not zero. You will never have a p-value of zero, but because it's very, 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 very small, it means it's very much at the extreme of the distribution. The SPSS will not give you the exact number. It will just give you this. And that's why in papers, you will find less than 0.0001. So this is indicating a highly significant association. Since the p-value is less than 0.05, the conclusion will be that the blood pressure for all patients admitted to the ED after an MI is significantly higher than the normal value, which is 120. So I'm reflecting on the population as compared to the 120 value that I took. This is an interpretation of the p-values. This is a t-distribution. I'm not going to go in details about it, but I just want you to know that the t-test that we use is exactly the same as the z-test that we use. The distribution is exactly the same. There's a little bit of change in the distribution, which is taken care for small sample sizes. This is the table that is for the t-table. I'm not going to go over it. Let me go for hypotheses. So different hypotheses. I might have a hypothesis where I'm saying the average in one group is equal to the average in another group, or proportion in one is equal to the proportion in the second one, and so on. Let me go to compare two means. Before I go to compare two means, if I want you to get something out of this session, I want you to understand this slide. This slide is telling you the different tests that we use. So you open a paper, you look at the statistical analysis section, you will find something about a chi-square or a t-test or an Anova. So in this slide, I'll be explaining to you which one is used for what. So if I have a categorical variable, if you remember from last session, I should have mentioned something about all statistical analyses are decided upon by what type of variables you have. So now when I'm associating or I'm doing an association between two variables, if the two variables are categorical and categorical, I use a test called chi-square. So whenever you read a chi-square, you should understand that this p-value was calculated through this test because I have two categorical variables. Assume that I have a clinical trial, group A, group B. The outcome is mortality, yes, no. So the two variables are two categorical variables. The p-value to see the association between these two variables is the chi-square test. If I have two continuous variables, assume that I have the dose for a certain medication as an exposure, 1 milligram, 2 milligrams, 3 milligrams, or whatever. It is a continuous variable. The outcome is length of stay in the hospital or in the ICU. It's another continuous variable. I do a correlation test, which is correlation coefficient R. If I have one categorical, one continuous, I have multiple scenarios. I have the independent t-test, which is the most frequently used one. Assume that I have a clinical trial, group A, group B, and the outcome is length of stay in the ICU. So one is categorical, which is the intervention, group A, group B. The continuous is the length of stay in the ICU. I do an independent t-test. Why do I call it independent? Because those in the intervention group are completely different than those in the control group. That's why I do independent test. A paired t-test is when I have something that's dependent on each other. For instance, if I do an intervention, I measure the blood pressure before the intervention and blood pressure after the intervention. So I have a categorical variable, which is before, after. I have a continuous variable, which is the blood pressure. But the problem is that the before and after are dependent on each other because they are for the same patient. That's why I cannot do independent t-test, I do a per t-test. The last test that I want to tell you about is the Anova. The Anova is called the analysis of variance. It's exactly the same as the independent t-test, but instead of having 2 groups, I have 3 and more groups. So for instance, assume that I'm doing a clinical trial, but instead of having only intervention and control, I have 2 interventions. So I have group A that are taking 1 medication, group B that is taking another medication, and group C, which is a placebo. So the categorical variable now is 3 levels, A, B, C, or 1, 2, 3, or whatever. And the continuous variable is length of stay in the ICU. Thus, I cannot use independent t-test because independent t-test takes only 2 groups. The Anova is the test that I should be using. By now, I would have finished my presentation. I'll take a few minutes to just rush through the remaining 10 slides to show you what it means for each of these tests. This is an independent t-test. I have males, females. Blood pressure is the continuous variable. I found 145, 138. There is a difference. Is this difference significant or not? I do the null hypothesis, which says the blood pressure for males is equal to the blood pressure for females, or the difference is equal to 0. The alternative, they are not equal to each other, or the difference is not equal to 0. How do we carry the test, or which test do we use? The independent t-test. This is the same interpretation, p-value more than 0.05, less than 0.05. The interpretation is exactly the same. This is the output. You don't need to read the output, but this is the p-value, 0.269. And eventually, 0.269, it is more than 0.05, meaning not significant, meaning null hypothesis is accepted. This is an example of a clinical trial. If I show you the age, I have 2 groups, continuous variable, 51.3, 51.7. The null hypothesis, the averages are equal to each other, alternative not equal to each other. This p-value is calculated by a t-test, and you know why? The p-value is 0.89, more than 0.05, it means no significant difference. The per t-test is done when I want to compare before, after. In our example, heart rate at admission, heart rate at discharge, I look at it and I find that the heart rate decreased from 81 to 76. What is the null hypothesis? The difference in heart rates is equal to 0, or the difference is not equal to 0. I look at the p-value in my output here, it is 0.133, more than 0.05, meaning no significant difference in heart rate between admission and discharge. This is also the interpretation for the same thing. The Anova is the analysis of variance. I'm gonna give you the hypothesis. Since I have more than 2 groups, then the null hypothesis is saying the average of the first group is equal to the average of the second, is equal to the average of the third, and so on. The alternative, one of them is not equal to each other. And eventually, what I get is, I'm skipping them. This is the output of Anova. I got 0.859, means not significant. I accept the null hypothesis, meaning there is no association between the continuous and the categorical variable. The chi-square is when I have 2 categorical variables. This is an example of 2 categorical variables, gender and hypertension. I go look among males, 21.4% are hypertensive. Among females, 45.5% are hypertensive. There is a difference in hypertension probability between males and females, but is it significant? So I go and do the null hypothesis, alternative hypothesis. The null hypothesis is that proportion of hypertensive people in males is equal to the proportion of hypertensive people in females. And here it is not equal to each other. The test is chi-square test. And this is how I calculate calculated. I'm not going to go into it. And eventually, the output from SPSS is Pearson chi-square. P-value is 0.001, less than 0.05. I would reject the null, accept the alternative. I would say there is a significant association between gender and hypertension. This is the example of the clinical trial that I showed you before. I found 61% versus 60%. This is the null and the alternative. Chi-square test was used to get 0.96. The conclusion, no significant difference. This is a summary of the all the tests that I showed you. Whenever I have categorical and categorical, it is chi-square. 2 levels and continuous, it's t-test. More than 2 levels and continuous, it's Anova. What's remaining is the correlation, which I need 2 minutes to finish. Correlation is a measure that goes from -1 to +1, and it measures linear association. +1 is, it means a positive association. -1 is, means a negative correlation. This is an example of a correlation. Both are continuous. So as X is increasing, Y is increasing, but in a very nice linear fashion. So since one is increasing with the other, it is +1. Similarly, there is no straight line here, but the trend is upwards. So as X is increasing, Y is increasing, but not in a perfect way. That's why the correlation R was found to be 0.66. In this case, it's perfect negative, -1. In this case, it is minus 0.66, meaning there's a negative correlation with not a perfect distribution. So the bottom line, if R is equal to 0, it means no association. If R is more than 0, it means positive association. And if R is less than 0, it is negative association. And this is exactly the same example. And the last slide I will give you, this is an association between heart rate and blood pressure. The null hypothesis is that the correlation is equal to 0, meaning no association. The alternative is that it's different than 0. I found a correlation of plus 0.55. The p-value is less than 0.05. The conclusion will be there is a significant association between heart rate and blood pressure. And this is the end of my presentation. Sorry, I rushed it a little bit. We still have a few minutes. If you care about asking any question, I'll be happy to explain it further.
Thank you, Dr. Hani. It's a great overview. Very important concepts and principles to fully understand. So we'll have some time for a few questions. You could raise hand or put a question in the chat. So question, Hani, about the relation between p-value and sample size. So sometimes p-value is not significant, not because actually there is no difference, but because the sample size is small, right?
Yes.
Can you elaborate more on this?
Yes. So I will go back to exactly what I was talking about with the standard error. So the p-value, if you want to calculate the p-value, it's exactly the same as the confidence interval. The confidence interval, we did the average plus minus standard error, which is standard deviation over square root of n. Now for the p-value, it's the opposite, but also I do the standard deviation over square root of n. So as n increases, the p-value will decrease because the distribution will get narrower. So that's why if you have 300 patients and you got a p-value of 0.06, if you increase your sample size by 50 patients, the p-value by calculation and because of the standard error, dividing by the sample size, it will become smaller and it will become 0.04. That's why some people manipulate their analysis by just increasing their sample size a little bit to reach a statistical significance. I'm not sure if it answers the question.
No, this is excellent. Any questions from the audience? can you also elaborate on the issue of statistical difference and causality? For example, correlation. Does correlation indicate causality by itself or no?
So you mean statistical versus clinical, or causality as in the criteria for
Well,
causality?
yeah, part of it. Yeah, maybe part of it also.
Clinical statistical?
Yes.
Okay. So let me do this. I hope I can. Okay. So I have statistical significance and clinical significance. I'm sorry, you have to tolerate my the handwriting. So basically, sometimes if you have a small sample size that's very small, the difference might be clinically significant, but not statistically significant. Because the sample size is small, the p-value was large. You were not able to reach statistical significance. But if the sample size is large, is big, you might have statistical significance, but not clinical significance. So assume that I have a difference between two groups in length of stay in the ICU of 0.5 days. So, or a few hours. It might not be clinically significant, but because you included a huge sample size, it was found to be statistically significant. The same thing, you might have few days different, which is clinically very important, but statistically, because you took small sample size in your study, it's not statistically significant. So these are two challenging scenarios that we have. The best scenario is if you have statistical and clinical, it will be easy to interpret, or if it is not statistically significant and it is not clinically significant, it will be easy to interpret. But whenever you have a scenario where they are contradicting with each other, you have to give the clinical significance more importance, because this is what it boils down to. So Dr. Yassin, most probably you will, if there's something you want to add, I think you will.
No, this explains it very well, very nice. So sometimes with the very large sample size, you could see differences that are really minor and they have no significant, no clinical impact. I thought Dr. Hani Timsah has his hand raised.
Yes, I saw it.
Wallahi, it's very wonderfully elaborated. I'm really very, mashallah, excellent topic. Excellent way you presented it, Dr. Hani. Really, thank you very much. I follow your publications. Our names are similar, but you are superb, mashallah. Sorry.
Shukran.
I enjoyed it. And I do hope that through the society, if possible, Prof. Yassin, to make this presentation and the previous one, if we have the recording, I think it will be wonderful to share it in the YouTube channel of the society. I think it's wonderful to share with our residents, our trainees. You made it very nicely explained. Thank you, Dr. Hani.
Thank you. With pleasure. I don't have any problem.
Thank you.
Great suggestion, Dr. Hani. We'll make it available.
Okay.
Any other comments? If no other additional comments, I'd like to thank you, Dr. Hani Tamim, for this excellent presentation. And maybe in a few months, we'll invite you again to give another follow-up presentation, maybe about the graphical presentation of data. Well, I think that will be very useful. So again, thank you again, and have a good night, everyone.
Pleasure. Thank you very much. And inshallah, I'll meet you in future occasions. Thanks.
يكون العافية. مع السلامة.